And before we begin, I want to start with a few logistics. This meeting will be recorded, and we will share it on Workplace. While our presenters are speaking, you might see that I've muted you on entry just to reduce unnecessary noise, but we will unmute you for the question and commentary portion of this. Though while our presenters are speaking, I do urge you to use the chat box. And now I will turn it over to our voice projecting Dr. Lisa Letourneau, who will be moderating today.
Great, thank you, Kelly, and apologies in advance if there are any issues. I'm not sure quite what's going on with my voice here, but are people hearing me okay? Bill, can you give me a thumbs up? Is that all right? Okay, great. So we're thrilled to have you all joining us today and really pleased to be sharing some really innovative approaches to getting choosing wisely into practice. So we're starting with Dr. Cate McKegney and Dr. Bill Doherty. Dr. McKegney is a family physician with many years' experience in patient care and teaching in a variety of settings, including private practice, county hospital, and clinic, as well as nursing homes and transitional rehab units. Since medical school, she's focused strongly on how to improve the clinician-patient relationship and how to influence the process of treating illness and recovery. With her is Dr. Bill Doherty, a professor at the University of Minnesota in family social science, family medicine, and community health. He's a family therapist with many years' experience working with primary care clinicians and is a co-founder of the highly innovative, much beloved movement called Boomers for Balanced Healthcare. So with that, Bill and Cate.
All right, so wonderful to be with you all and to share something that's been in development for a couple of years now, and that is a guide, a podcast guide for how clinicians can talk with patients about overuse. So if we could go to the next slide, then we'll get rolling. So a little bit about baby boomers for balanced healthcare, and thanks for your check will be in the mail, Lisa, for giving us a good endorsement there. So it's a group of citizen baby boomers who believe that healthcare spending is out of control and will bankrupt our country unless we all take responsibility for changing how we do healthcare. We want to stimulate a local and national conversation about changing the cultural belief that more healthcare is better healthcare. And of course, this is what you all have been working on and choosing wisely. In today's healthcare system, as we all know, there are too many tests, procedures, and services that don't help and can harm. We're overdosing on healthcare. So what Baby Boomers for Balanced Healthcare does is we sponsor community conversations about medical overuse. And we decided to develop a guide for clinicians on these conversations. And I'll tell you a little background story. I was speaking with a group of mostly physicians, some nurse practitioners as well, about this issue. And we decided to have them do one of our community conversations in which everybody in the room was a patient talking about their own experiences with overuse and that of their family. And at the end of it, a couple of the physicians present said, you know, we could use some help in how we have conversations with our patients, particularly when patients are asking for more than would be good for them. And so we came home from that and decided to start working on a clinician guide, particularly using the fact that Cate McKegney was in our group. A long-term internist, Jim Hart, had been one of the founders of our group. So we had patient resources, we had the clinician resources, and so we decided we would develop our guide. And so we worked on that for a period of time. And then we approached the HealthPartners Institute to partner on the project to really help really put it on the ground and then bring it to fruition. So this has been really a couple years of work and partnership. So if we could go to the next slide.
So our goal in developing these tools was to come up with practical tools for conversations with patients and families when those folks are asking for something that involves medical overuse. And as a group, Baby Boomers for Balanced Healthcare talked about reasons why these conversations are difficult. The patient may feel underserved or cut out of something that they're entitled to. There can be unproductive disagreement and power struggles, which never work out very well. And there may be third parties who are not present, especially other medical folks or family, who don't agree with the clinician who's trying to advocate for slightly less. Clinicians have not really been trained to have these conversations, and the conversations do take time. So the next slide, please.
So we decided to take this approach, to do a podcast series with simulated clinician-patient conversations followed by debriefing, and to do these extemporaneously rather than scripted. You're going to get a chance to hear one of these in a few minutes. So this was a major decision that our HealthPartners Institute colleagues and Cate and I made, that we would do these podcasts so people could listen to them in the car or anywhere, and rather than having to be tied to a computer screen or video screen, and to script out what the issue was, what the topics were, but then to have what you'll see is Cate as the physician, me as the patient or family member, then enacting it from there. So that's what we did on these, and to really do a debriefing where we kind of tease out what happened in the conversation. So that was a major decision. The second major decision was to use a variety of scenarios in which the patient or family makes a request for an unnecessary diagnostic test, a more aggressive treatment plan than is needed, and long-term opioid request for management of acute pain. So we decided to do 3 different kinds of areas rather than just one. Next slide, please.
As we worked through the different types of scenarios, testing, screening, treatment, et cetera, we recognized that it made sense to also present a spectrum of conversations that could happen in each of these cases. So we developed 4 conversations for each scenario, a routine conversation about how things often go in regular practice, and 3 more skilled conversations, a simple conversation, a complicated conversation, and a polarized conversation. Simple is where the intervention works pretty quickly, complicated takes more effort, and polarized takes lots of effort and doesn't necessarily work out well. I think Bill enjoyed those a little. And we then did a debrief after each one, reflecting on the differences in tone, style, language, and reflected on the clinician's experience and the patient's experience within the scenario, within the role play, as well as at times bringing in reflections from our personal experiences as clinicians and patients. Next slide, please. So the next thing that you'll hear is one of those conversations. This is the scenario where the patient asks for a prescription renewal for an opioid after elective hip replacement surgery. This segment represents one of the complicated conversations. In the podcast, it follows a simple conversation in which the physician has already explained the rationale for not renewing the prescription and reassures the patient about what to watch out for, what kind of follow-up is needed. In the simple conversation, the patient has accepted this approach. In this complicated conversation, we start at the point where instead of accepting the simple approach, the patient begins pushing back instead of going along with the plan. So if you could cue up the audio.
So the pain in your knee and your back and all that makes sense to me because you haven't been walking straight for quite a while when your hip was in the shape that X-ray shows me. It wasn't doing you any favors. Pain and strain in the other muscles and the other joints, it makes a lot of sense. It's kind of like you went out and shoveled snow from the standpoint of your back and your other leg.
So let me just say, Doc, I've shoveled a lot of snow. And I used to be a bit of an athlete in my younger days, and I've had aches and pains. I had knee surgery after a football injury, so it's not like I'm new to pain. But nothing like this. The hip is better, but the other stuff is bad. It doesn't. It just seems like it's been getting worse. Okay, and so I just think I need something more to ride this out here for a little while. That's what I'm saying.
Okay, it sounds like you're having more pain than you expected.
Yeah.
And in weird places.
Yep.
And you've had pain before. Tell me what you've been doing other than the oxycodone to help with the pain.
Well, some icing, of course, and some stretching. But once I ran out of the oxycodone, it's just too hard to do stretching, and even to walk around. So I've just been kind of laying low until I could get in here and we could just get a new plan here. Okay.
How much were you getting around before you had the surgery?
Well, not that much, because that's why I had the surgery. It was pretty. I was walking like a crab. But, that was me. Not the old football guy. Not the running back anymore. So that's better. But I got a buddy who had this surgery, and I swear he looked really chipper.
It is real different for different people. And it's hard when the one example in your life is somebody who seemed to spring from the operating room table. And
he didn't have any, he had oxycodone. He wasn't even taking it after 3 days. Okay? So anyway, I know everybody's different.
It's hard for me to know. Yeah, everybody's different. So you've been doing some of the stretching and some ice and taking some Tylenol and ibuprofen. What is it that you're most worried that this might be, that these pains might be?
I guess that where I'm going to end up, I'm going to be some sort of, I don't know, cripple's too big a word for it, but what I want to do is get back to walking, maybe even running, and it seems like, other than the hip, it seems like I'm going backwards. What I'm looking for is just to kind of get through the next few weeks without all this pain, and so I can sleep better, and then just let my body heal.
How long has it been since you were last walking the miles that you're hoping to walk?
A couple of years, probably.
What kind of plan did you have for when you'd be back at that?
Oh, my buddy was back in about a month.
And have you talked to anybody else about what to expect for this?
I don't remember at all.
When you've been basically not doing much for a couple of years, the time to get back there is going to be in months to more than a year.
Yeah, and I understand. Okay, I'm taking that in. But why not some more oxycodone for a while is really what I'm asking for here.
Because I don't want you to hurt yourself as you're getting better. And the oxycodone can make pain that you need to know about go away. We have to pay a little bit more attention to some of the pains because it can mean that we're doing things wrong or in a dangerous way. There may be some clues in that you need in order to rehab correctly. And I don't want the oxycodone to cover that. The other issue is oxycodone can cause terrible constipation, which we know how to treat. And when you're on oxycodone, your sleep isn't normal. And I want you having normal sleep because normal sleep is what helps with not having the pain so bad later.
So what's the plan?
It sounds like we need to get a very clear prescription for that, for what you do before, and then what exercises you do, and then what you do after, so that we can rehab the rest of your body from its compensation, getting around the fact that your hip didn't work.
And then medicine?
I want to try the ibuprofen and Tylenol in a scheduled fashion to get you through this transition.
Okay.
How does that sound?
Well, it sounds like a reasonable plan.
So we'll try this plan for, let's say, 3 weeks, and then I want to see you back.
Okay, it's a deal.
All right.
Okay, that's the end of the complicated conversation. More turbulence here. Let's talk about what happened in this scenario. I was hearing it all and buying maybe half of it.
Mm-hmm.
Okay, I even interrupted you to get some of my points, and that's probably a sign that the patient isn't buying it all. What was it like for you when you were on your roll, and then I said, no, that's not right?
What that means to me is that I need to stop talking and start asking questions. And there are two parts to that. One is if I ask you questions, you then feel that whatever it is we do next is centered on you.
Yeah.
And the other is that I'm less likely to recommend something that you've already tried and didn't like. And so that's when I asked, what have you been doing? How much activity have you been getting? Because you had heightened emotion, I asked about emotion. I asked what you're most worried about or most scared of.
Yeah.
And you told me you were worried about being a cripple.
Right.
And then you were comparing yourself to your buddy.
So that all came out when you asked questions and got into what I was thinking and feeling. I want to underline that when I wasn't buying fully, you had a choice point. You could have talked more. It's so tempting when I said I'm not fully persuaded for the clinician to pull out more persuasive ideas, okay, and facts. Isn't this more patient-centered and more altruistic? It actually makes your life easier because if you had given a little lecture, I'm sitting here ready to say I'm not buying that either.
Exactly. On the other hand, if I asked you a question and you have to come up with something,
right.
then we're both working.
Yeah, and the thing is, the question did not have a negative edge to it.
And it was not a question I knew the answer to.
So I was now aware when you asked that question that I was going to have to fess up that I wasn't doing everything. Okay, so two things. First would be double down on the facts. Okay, the other one would be to say, and so what have you been trying? Or,
well, you haven't been doing the stretching like you were instructed.
Yeah.
Well, or when you fess up to that, for me to say, well, that's why.
Yeah, exactly. And in other words, we would be continuing to have an argument, and you would have chosen the path of letting me trap myself. But instead, you just stayed even keel, and your question about what I was doing was an open question, and you didn't just sort of say, well, that's it. So we were not in an argument about whether you were correct.
And part of coming up with a clear plan would be to sit with you and say what feels possible and what worked before.
Yeah.
I also in there was asking what your expectations were, and again, your friend getting better, and to acknowledge if it takes you 2 years to get into this, it's not going to come out in a month.
Yeah, you were recalibrating my expectations. And a key moment for me was when I started talking about my buddy. Because it was all calibrated to him. He was off the meds, the pain meds. He at least said he was walking, And for a lot of patients, there are these comparisons, right? I had my N of 1, okay? And I used to be an athlete, so I got that into the conversation. And when you asked me what was I really afraid of, okay, that was a hard moment for me because I'm this ex-athlete guy. I didn't really want to have to say I'm afraid of. I didn't even tell you all of it, but you could probably sense that I had some fears, and that I didn't have to kind of spill all out. But that was an important moment when you said, what are you most worried about here?
And that was part of why I came back later to, you can get back there, but it's not going to happen accidentally.
Yeah. So that was the other thing here, that you got very systematic. We need to plot out your use of the ice and the stretching. We need to plot out your use of the over-the-counter meds, because I think as a patient, what I'm used to is the plotting out is the prescription stuff and the doctor-centered stuff, and these were all me-centered things in terms of, well, at least the medicine, it's over-the-counter and so on. But I felt reassured when you were talking about a written, definite plan, as opposed to, well, you're off the heavy-duty meds and just take the over-the-counter stuff and do your physical therapy. And that would be, I would have felt less supported than when you said, we need to write this stuff down.
Your distress makes you less organized. And so you wanted something from me, and I can give you something.
Yeah. So that was comforting. Does that make sense? That it was the level of my level of emotional distress, which makes me less organized, and I was not there with my wife and all that. That where you said, okay, let's have a plan, and I felt my blood pressure go down when you said, okay, let's do a plan. Let's do a plan.
And instead of and if it's not working, see me in 3 weeks, there was a definite deadline. I want to see you in 3 weeks.
I want to see you.
And which also means that I will be expecting to hear about how this plan went. There's this sort of a double, I care, I want to see you, and...
So accountability here. That was a difference here from the more simple one where I could be back in touch with you.
Yeah.
So here you said, I do want to see you.
Yeah.
And then that allows me to go home to my wife and others who, she's distressed with my distress. And here's what the doctor said. It wasn't everything I hoped for, but she wants to see me. She gave me this plan, and she wants to see me back. And so that gives a time frame when I'm expected to be here, not that I have to sort of decide on my own. So this one made you work harder. What did it feel like?
Well, it was certainly more satisfying than the first one we did, the more routine. I'm a little more concerned about your pain and whether indeed we have unveiled some knee problems or back problems that you just hadn't noticed.
In terms of just your feelings yourself.
This was more satisfying. Okay. It felt like we got to being on the same page.
Yeah.
I'm not as convinced that all will go smoothly, but...
My point is that you felt you were doing your job here as a doctor. And so this has gotten to be something that you feel you can do. You can rise to that occasion. You weren't breaking into a sweat about this. And I would imagine afterwards you don't go, darn, that guy was trouble.
No, I'm giving you hope.
So let me end on the note that I felt this reassuring, almost the cheerleader from you at the end. And it worked and it felt good because of where you had gone with me up to that point. It didn't feel like a rah-rah that was ungrounded in where I am. And it's the timing of that, because I felt heard, we had a plan, and then you could say, I believe you can, I know you can do this, right? And at that point, you shifted into a cheerleader role, and it felt good at that moment. In a way, if you had done it before then, I might have had to argue back with you.
Yep.
Okay.
All right.
Good.
Great. Well, thanks so much. I think we will hold questions for the end, but Bill and Cate, anything else you want to add?
Just to say that there's lots more where that came from. And I probably have listened to it 10 times, but I'm always quite fascinated by what's going on there. So to be continued. Look forward to questions.
Super. Great. Well, that was fantastic. Thank you. All right. So we're going to next move to Christine Bloom, who's a partner in this effort. Christine is a Director of Quality Improvement for Corporate Services at Park Nicollet. In that role, she supports quality improvement within the corporate service areas for Park Nicollet and provides oversight for the ABIM for Medical Specialties Portfolio Program at HealthPartners. So with that, Christine, I'll turn it to you.
Thank you very much. We're excited to actually kind of start to share some of this work that we've done. Like Bill said, it's been a long process and a very organic process to get this started. So let me just give you a little overview of HealthPartners. The ABIM asked me to share how we plan to use this tool within our healthcare system to kind of help give ideas to others out there who also might like to use this. HealthPartners is an integrated healthcare organization in Minnesota, in Minneapolis. It's the largest consumer-governed nonprofit healthcare organization in the nation. We have about 1.8 million medical and dental health plan members. And our care system includes a multi-specialty group. We have about 1,800 physicians and 1.2 million patients, about 26,000 employees, and it's about 90-plus clinics and hospitals within our system. So that gives you a little idea of kind of the structure in which we would roll out something like this. So I think people probably ask why podcasts on medical overuse, and when Bill kind of brought this idea forward and the baby boomers group brought this forward, when we looked at it, these were some of the reasons as to why we said, yes, we should be doing this as an organization. One, it supports HealthPartners' organizational strategic plan in so many ways. I'm sure like lots of healthcare organizations out there, we have lots of work going around opioid prescribing and antimicrobial stewardship and de-prescribing, among other quality improvement work within the system. We also really felt like this reflected our mission, vision, and values. If you look at our mission, vision, and values at HealthPartners, partnership and relationships is in almost every sentence. So being able to kind of partner with the baby boomers group and Bill and Cate was ranked right up there as to why we decided to kind of work with them on this. As you guys mentioned previously, this is a really innovative format, and as we started to talk and scope and think about how we would use this and collect information from our medical education department and what they were hearing physicians, there was definitely an ask for some more innovative ways to get information to them, one of them being podcasts. A lot of our clinicians, the only time of the day that they actually have to listen and do education is on their drive or their commute to the hospitals and clinics. So how can we hit that target audience with some sort of education that actually fits into kind of their daily work? So the podcast format seemed like a great thing for us to try. We also thought that this really, we could use this as a resource for a lot of our existing programs. We have a clinician shadow coaching program, which I can talk a little bit more about as we go. As well as our medical education group could use this in a lot of their regional conferences and regularly scheduled series. We also have a strong graduate medical education group, so to be able to use this with residents, specifically our family medicine residents, was a huge push as they have to do quality improvement work before they sit for their boards. So we just saw a lot of places that this type of format and this content could be used within our system. And then, like was mentioned previously, this chance to partner with our community and the baby boomers for balanced healthcare, Bill and Cate, has just been a really tremendous experience. So I would say the key to this working was this organizational partnership piece. This is a grassroots effort. There was no budget kind of aligned with this work. So how can we use the resources that we have within our system to make this happen and within our community? So we relied heavily on our patient education department. They helped pull together the guide that everyone will have access to, the patient materials that are attached for each conversation to help physicians and patients. They also did a tremendous amount of editing. Our continuing medical education department talking through how would we give this credit, what would it look like for physicians and clinicians. Our portfolio program, we're an ABMS multi-specialty portfolio program. So how do we create a quality improvement effort that our physicians could use this content to meet some of their Part 4 and requirements going forward? Also, our Office of Health Professional Education, which is our turned out to be a tremendous resource. They had the technology expertise to be able to do this. None of us really had a whole lot of experience working with podcasts in that format. So we actually wound up having a physician in our emergency medicine department at one of our hospitals that one of his passions and kind of his own personal development was to learn how to podcast. and create podcasts. So spent a lot of time working with him on like what would this look like and sound, and how do we push this out to Apple and Google Play. So again, just using a lot of internal resources and grassroots to kind of pull this all together. And then obviously the expertise, both from the physicians and partners across our organization, and from, the baby boomers for bringing content back and having it looked at, all played a huge, huge role in this type of development. So the ABIM asked for some kind of initial feedback on the podcast. We have not launched this in our system, and I'll talk a little bit about that in the next few slides. We will start in January of 2019, but we went through a ton of feedback sessions on the content, the format, the process, and these are just a few of the things that we kind of pulled out and brought forward. We were glad to see I'm able to listen on my way to work, because we hear that a lot from our clinicians, that give me something I can do while I'm in the car. And then also just people really liking the unscripted role play. We went back and forth on that. Should it be scripted, unscripted? What do people think? People love the kind of commentary at the end with the physicians commentating on how the conversation made them feel. So it had some great feedback, so that kind of gave us the energy to keep developing and adding more and additional types of conversation. So I would say great initial feedback. I'm excited to see what happens when we roll this out across our organization, because we'll continue to take feedback, especially, should we develop more podcast type medical education for our clinician groups and for others that would like to use it. So how we kind of plan to use this tool within the HealthPartners system, like I said, will be rolled out in 2019. It's kind of multifaceted. This is a large part of our strategic initiative related to medical overuse. We have work groups working on antimicrobial stewardship. It will become a training resource for them. There are groups working on deprescribing. So it will become for medications that are no longer offering benefit for our patients, we're hoping they can use it to help with conversations there. A large work group working on opioid prescribing. It will become an educational resource for that. Some of that will be weaved into some of the mandatory education that will also be rolled out. So lots of ways strategically that we'll start to embed it and make those available. Also looking at, how do we use this within programs that we already have internally, and I had mentioned our shadow coaching program, which is a clinician communication skills coaching program that we offer here at HealthPartners. And so this will be a tool that those coaches can then use with physicians after they've been shadowed and provided feedback. So they're really looking forward to be able to offer this as a resource for the clinicians that sign up for that shadow coaching program going forward. And then also with our family medicine residency programs, we have a large program here, and our family medicine residents get very involved in our maintenance of certification portfolio program, as they all do a quality project before they sit for their boards. So we've worked a lot with them on some of the other large scale things like documentation efficiency and things that they would really need to be up to speed on as they move out of their residency. So this communication skills one was a huge hit with the residents in terms of kind of gaining some knowledge and understanding and around communication skills. So we're looking forward to using that with them and offering that with our residency programs as well. Lastly, our MOC Part 4 and the PICME opportunities, this will get rolled out as its own individual activity through the portfolio program. So clinicians can earn their Part 4 and CME credit, PICME credit for all of our PAs as well. It's a 6-month self-directed improvement project. They're going to use some of their patient experience data, their NRC Connect data that physicians get monthly around their composite communication scores. And they'll develop personalized action plans to kind of adopt skills that are demonstrated within the podcast. There's also a fair amount of subjective data that we'll be collecting for them about frequency of ordering and how often are you feeling like you're being pressured to order something or prescribe something that you don't necessarily feel is the best evidence-based approach. So we'll collect a lot of subjective data like that from them as well as they go through the process. And then the podcast can simply be viewed or listened to via iTunes and Google Play by anyone. They have been pushed to iTunes and Google Play, and we've been told it takes anywhere from 1 to 3 weeks for the content to be reviewed before they're made public by iTunes and Google Play. With that, people will be able to have access to the listening guide that was developed as well, and then there are links for patient education materials available as well for that. So I think that's all I have. I'm more than happy to answer any in-depth questions around how we do this, what we're going to do, provide examples, etc. for those who are interested in some of that credit-based application of these podcasts going forward.
Terrific. Well, thank you so much, Christine, for sharing your thoughts on how you're going to put those great tools into practice. And again, Bill and Cate for sharing the work on the podcast. I think it's just fascinating in terms of a whole new way to make it real, right? I mean, I think that's a lot of the issue sometimes with choosing wisely is physicians think it's a great idea, and then how do I implement it? So fantastic thought on that. Time to invite folks to ask questions. I think it looks like we've unmuted most of the lines. If you aren't speaking, you might want to mute just to cut down on, got a little background noise going, but open it up to questions. Well, I'll ask one to start, and that is, Christine, particularly if you have any experience. I know this podcast hasn't been put out there yet, but experience yet with sharing podcasts as a way for clinicians to access CME or support behavior change. And again, if folks don't mind muting, if you're not speaking, that might be helpful. But or have you seen in other organizations? Have you seen podcasts used?
Lisa, I haven't. This was the idea of creating a podcast was really new for myself, and I think most of the staff involved. So we kind of went at it from, like I had mentioned, that we had just a number of physicians asking for, how can you reach us where we're at, which was we want some education while we're driving to and from work or while we're sitting at the airport. And, a lot of them were like, this is how we get our journal articles. They're fed to us, and I can listen to them while I'm waiting for my plane or whatever it might be. So I think we kind of felt like let's try this. We also, we looked at doing video. Video is often very expensive, and then it requires you to be in front of a computer sometimes. So I think the use of the audio with lack of budget was a great decision. And then the idea of podcasting was just something new and novel, at least for us and our medical education area.
Great. And I'm seeing a related question. Nancy Yedlin, in places and practices where groups have used these tools, what kind of feedback are you getting on their uptake? So you've addressed that somewhat. I'll also share at Maine Quality Counts, my home organization, we make our webinars available as podcasts, and that's been one of the most popular ways that providers have accessed our materials. So certainly it's been very positive. Not this, obviously topic specifically, but more generally education. I agree with you. Their ability to flip something on in the car right while they're driving and not add another hour to their day has been hugely popular. How about Bill or Cate, when you've gone out and talked to crowds about this, or have you? I know again that it's not widely out there yet because it's the beginning of this effort, but have you had feedback from clinicians who you've spoken with about their likelihood to use this, their interest?
Oh, so Cate, I don't know if you want to comment on that. I was, if you don't mind, I'll sort of pivot a little bit, Lisa. One of the reasons we decided to do the simple conversation as well as the polarized. The simple because sometimes those conversations can be relatively brief. You don't need to bring out all of the charts and all of the data. There's some protocols for shared decision-making, for example, that are maybe a bit of overkill when the patient is basically ready to accept your view on the issue. So the simple one, just sort of, you get in and out of the conversation pretty efficiently. And then we did the polarized ones, and we don't have time today to do one of those, but how to survive as the clinician and also not beat up on the patient when the patient simply does not accept this, is upset, it feels deprived of good care, gets angry. And Cate does really a great job of managing that. And our thought about why to have that one, because it could be looked like a failure conversation in communication, right? I mean, just patient ends up, in some cases, firing the doctor. Because what we've heard from some clinicians, and this dovetails back to your question, is that it's the feeling of not knowing how to handle the worst case scenarios that gets them to give in too soon, that they sort of punt. Patient's upset, family member's upset, and I don't want to be here for the next 45 minutes in a yelling match, and so I'm just going to give in. And so so that's part of why we decided to show some of the skills for conversations in which the patient or family member, at the end of the day, do not buy what you're saying. So that you can feel that you've ended that conversation in a way that you treated the patient with respect, your dignity is intact, and you both move on. So we've heard some of that. It's like we need skills to manage very difficult situations. So we can talk about the others as well.
And I haven't done presentations specifically with this framework, but I certainly, as I used to tell residents when I was teaching more, is that it's not so much that I know how not to step on patients' or families' toes, but I get good at apologizing for doing it. And I can apologize for disagreeing with somebody without giving in. I can be regretful that we don't see eye to eye on this, and I'm not going to give you exactly what you're asking for, but I don't have to wound you or get wounded myself on our way out the door, which many residents have been grateful for. How to go home without having said mean things to a patient, which is very painful to me. I've done it, and avoiding doing it feels better.
Great.
And
how to have that difficult conversation in a respectful way. So, yeah, great tools. I'm also seeing from Bill Adams, and folks feel free to unmute, but when we've talked with physicians, the usual response has been, how soon can we get this? So that's great. And then Kelly had noted also be linking to the podcast on the ABIMF website once they're publicly available in January. Super. Other questions, thoughts, similar experiences?
Lisa, I think I would just add, kind of taking off what Cate and Bill just said, about building that understanding of conversations and crucial conversations. We do all of this stuff in healthcare, especially within quality, where we put hard stops in EPIC and you're not allowed to prescribe, or it sends you down a different path. So we do all of that with the technology behind the scenes, but do we ever really work with clinicians on that communication piece? So I see this as just being a great add-on to all of this other cool technology that we're now implementing within our organizations to be able to help support physicians in that process. Now there's those hard stops, but there's also those skills to be able to say, I can have this conversation and I can practice this conversation.
Mm-hmm, mm-hmm. Great. Other thoughts, questions? Who could envision, we'll try the little raise hand function. I think everybody has that. Who could envision spreading these tools through your organization? Anybody know how to raise their hand? Can everybody raise their hand, Kelly?
Okay. if you look at the bottom where it says more options,
Say that again, Kelly. If you look at the bottom, what?
you should be able to raise your hand down at, there's a bottom toolbar that lets you raise your hand, but everyone should be able to raise their hand.
Okay. Just not seeing it.
Lisa, there have been some names appearing on the screen, but I don't know if you can see that. Kelly, somebody, I don't know if you're, it looks like some people may be trying to get in, but I'm not sure you're seeing them or how they do it.
I am seeing it. Kelly McKegney, actually my colleague.
Oh, got it. Okay.
I think it means people are unmuted and there may be some indication they're trying to speak. I don't know, Kelly, or just the mic is open, one or the other.
Me? How's that?
There we go.
Okay. No, I wasn't trying to get in. I probably accidentally crushed a button there, but I think this is an incredible opportunity. I know we're working on some health equity kinds of ways that we can reach providers, and perhaps down the road with the crucial conversations, health equity could be a lens in which we look through. So great stuff. Very exciting.
Kelly, I'm interested if you could expand that a little bit, the equity lens. Could you say more about that?
Yeah, I think, what you're getting to with these crucial conversations and beginning to understand and go down to the next level of working with people from different cultures, different experiences, trying to figure out ways to speak to their cultural sensitivities. And so many of us across the country work with, a diverse group of people who are coming in as patients, and perhaps that could be something we can put this type of technology in, in the podcast lens to incorporate some of that. We can get you some really great reports from the Connecticut Choosing Wisely Collaborative. They've done a lot of work with ABIM. ABIM is informed of it. So Kelly, you might want to talk a little bit about it. But it's kind of an interesting take on choosing wisely, but yet putting the health equity lens on it to ensure that we all have a better understanding and the cultural sensitivities of the patients in which we serve.
Yeah, and as Kelly teased, we also worked off of the Connecticut focus groups that they did and just completed a round of focus groups with low-income patients to find out how they felt about talking about overuse. And Kelly, I think you're right. Podcast is an interesting thing to think about in sharing some of that knowledge.
Great.
One of the things that's going to happen in our partnership with HealthPartners after the rollout in the winter is community conversations about overuse, community conversations that the Baby Boomers Group has developed and piloted, and a feature of those is bringing together people for conversations about the cultural belief that more is better in healthcare, and how most of us have absorbed that. Examples in their lives or their family lives where that's been a challenge, and ideas that people have about how they can, in their own world, in a responsible, respectful way, resist the cultural pull for more is better, and to have respectful conversations with their clinicians if they are concerned about whether something that they're being asked to do is appropriate, is good for them. And then, so we're hoping with the HealthPartners to kind of roll that out in the community. And I'll say that I remember when we initially talked with clinicians at HealthPartners about doing the clinician guide and that training, there was an eagerness to think about how patients and community members can be engaged in the same conversation. And that's really why the Baby Boomers Group really got going, because if this idea of more balanced healthcare, which means in some cases de-prescribing and so on, if that's only done, it's only initiated, that conversation is only carried on at the level of professionals, then it may not really fit in the culture, and it gets pulled back. If you have a competitor group who is saying, we go all out for our patients. We do anything for our patients. And so part of what we're trying to do with the Baby Boomers Balanced Healthcare Project is some kind of cultural conversations that would go in parallel to the kinds of conversations that Choosing Wisely is doing. And so we have that, and we've tested it and piloted and followed up with people. We have training videos on it. And we have an additional one that we have not yet piloted, but we hope to do next year. And that is a workshop for people who are concerned that a loved one may be involved in medical overuse. You have a loved one who seems to be on opioids forever, for example, engaged in what could look like polypharmacy. How do you, without undermining their clinicians, how do you address this? How do you bring up your concerns? How do you engage in a conversation when a loved one, a good friend, is involved in something that's giving you concerns? So we're hoping to roll that out as a workshop as well. Again, the theme being that this is not just about sort of proper medical care and balanced medical care. It's also about a kind of cultural shift towards care that is appropriately balanced. And so that's the next phase of our partnership with HealthPartners, and we're happy to share that with others around the country as well.
Great.
To emphasize one part of what you said, Bill, we call ourselves baby boomers for balanced health care, not baby boomers for less health care, because there are some things that need to happen more in healthcare to be safer and cheaper, and there are some things that need to happen less. But I think one of the things we referenced when we first started was the whole designated driver campaign, which we fantasized would be it is a cultural icon we would love to have develop about talking about balancing our healthcare in this culture, acknowledging that that's aiming a bit high, but just that there be a norm for talking about is more better, is less better, so that my personal selfish wish is that this be a cultural norm, so I'm not the one bringing it up in every conversation, that I'm not always the one talking with family or individuals about, does this make sense to do this, or what makes sense to do?
There would be lots of Cates around.
Well, and not Cate the doctor, but it's kind of like exercise 35 years ago when I started in medicine, as everybody thought, oh, you want to turn me into a marathon runner. Well, it's more normative now. There's silver sneakers, there's walking groups, there are all sorts of things. When I talk about being more active, I don't have to start from Active 101. There's a cultural norm that being more active gently is healthier for you. And our hope is that will also happen when we talk about what makes sense in terms of your health care.
I can tell you a little sneak peek from our focus groups that people overall were incredibly grateful with the idea that there would be some guidance in how to do this, and very receptive to the idea, but very grateful for the idea that there might be some help.
Terrific. All right. And Kelly has graciously put in the link for those community conversations from the University of Minnesota. So thank you, Kelly. So any last comments or questions from the group?
We're just eager to see how this works out there, eager to partner with people, eager to improve it. So and grateful for this opportunity to share it.
Super. Well, thank you all. Thank you, Bill, Cate, Christine, for this really pioneering work. We're really excited about it. We wish you well and love to see others pick up on it as well. So we will certainly encourage folks in this network to spread the word as well. So, Kelly Rand, anything else from your end?
Just, again, a thank you to all the speakers today, and as someone who got to hear a sneak peek of all the podcasts, they really are amazing. We will be sharing the recording on Workplace, but if you're not on Workplace, you can email me to receive the recording as well. And thank you for everybody who showed up today, but particularly to the speakers. So thanks so much.
Great. Happy holidays all. We'll hopefully talk with you in January. Thank you again.
Bye-bye.
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 Bye-bye.